Okay, I want to thank the organizers for inviting me to discuss updates in GU cancers from the ASCO GU 2025 conference. And I apologize that I could not be there in person, but I hope we can learn something from these GU ASCO updates. So these are my disclosures. So we'll start with prostate cancer. We'll go from prostate to bladder and then kidney. So the prostate cancer therapeutic landscape has changed dramatically over the past few years. As you all know, the advent of a combination AR pathway inhibitors and androgen deprivation therapy in metastatic castrate-sensitive prostate cancer is here, still not utilized fully in the clinic, in the community, and I think we need to do better there. And then there is the advent of many other regimens for CRPC. As you can see in the first line setting, we have various PARP inhibitors plus androgen receptor pathway inhibitors. And then, of course, we have these other regimens out there, the radium, lutetium, PSMA, which I will discuss very soon. And also in the salvage setting, we need to remember there are, in addition to PARP inhibitors, lutetium PSMA, we also have pembrolizumab in select patients with TMB high disease or deficient mismatch repair. Now, I want to highlight this trial, the PSMA-4. This is not specifically from GU ASCO 2025, but I did want to highlight it because lutetium PSMA, as we know, has been approved for a few years in the mCRPC setting, post-docetaxel, post-AR pathway inhibitor setting. But now we have the expansion of the indication. The FDA recently approved lutetium PSMA in metastatic CRPC in patients where it is appropriate to delay taxane-based chemotherapy. So this is based on the PSMA-4 trial that I show you here, in which in the first-line mCRPC setting, lutetium PSMA versus an AR pathway inhibitor change led to improvement in PFS. As you can see, hazard ratio improved um, to 0.43. Survival was not met at this point. There was a huge amount of crossover, which confounded survival, which was a secondary endpoint. So now we have lutetium PSMA available in the first-line mCRPC setting in the patients with the appropriate PSMA positive metastatic CRPC. Now, what I wanted to highlight from GU ASCO 2025 is the TALA-PRO-2 trial. This is a trial that looked at talazoparib, a PARP inhibitor, plus enzalutamide in patients with mCRPC. And what was shown at the GU ASCO 25 is an update with longer follow-up for survival in unselected patients. So this is the trial. This is a first-line mCRPC trial, enzalutamide plus placebo versus enzalutamide plus talazoparib. As you can see, the primary endpoint is radiographic PFS in the all-comer intention to treat population. Now, this is the patient population, well balanced in both the arms. You can see that there were patients with HRR, including BRCA1, BRCA2 in a subset of patients. Now, what we know is that this combination is approved in patients in the first line setting for the HRR population only at this point. This is based on the improvement in the radiographic PFS. And now there's an update at GU ASCO 25, which also showed an improvement in survival in the HRR positive population. But what's interesting is in the intention to treat population, which is all comers, regardless of HRR positive or negative, there is an improvement not only in the progression-free survival, but also the overall survival. So the overall survival improved with a hazard ratio, as you see here, 0.796, with a median survival improving from 37 months to approximately 45 months. Then the investigators also looked at the subgroup of patients with none of these either BRCA alterations or the HRR alterations. And as you can see, there is some separation in the curve in both of these groups of patients, regardless in patients with no HRR and no BRCA alterations, as you can see. The toxicities were as expected with the myelosuppression seen and 8.5% discontinuation of talazoparib. Now, the quality of life was not affected negatively by the combination of talazoparib plus enzalutamide. So the bottom line is in this trial, the combination of PARP inhibitor therapy with talazoparib plus AR pathway inhibitor enzalutamide led to improvements in overall survival in the intention to treat population in patients who were unselected as well as who were selected for HRR gene alterations. The median survival in the talazoparib group in the intention to treat arm was 8.8 months longer, and this was statistically significant. So it remains to be seen what happens with this new data and update, whether the FDA will review this and change anything in the label. We're not sure. At the moment, this combination is approved in the HRR population in the first line MCRPC setting. Now, I did want to highlight a trial. This is not actually GU ASCO, but sticking with the MCRPC theme here, starting with MCRPC. This is a first-line study, piece 3, in which the combination of enzalutamide plus radium-223 improved overall survival as well as PFS. This is in the first-line MCRPC setting. Some of these patients had received previous docetaxel, really none of them had received a previous AR pathway inhibitor, so slightly different population than what we see in the clinic. But this was a somewhat impressive improvement in outcomes with this combination. So we need to wait and see what the regulatory agencies decide regarding this combination. There's also another combination out there with cabozantinib plus atezolizumab, which was also looked at in the MCRPC population. This is compared with a second novel hormonal agent in MCRPC patients. And this was a positive trial. The median PFS improved with a hazard ratio of 0.65, although the absolute numbers remain small, around 6.3-month median with cabo atezo. Really, in the liver metastasis population is where a bigger, more robust improvement in PFS was seen. Hazard ratio 0.43, tripling from 2.1 to 6.2 months median PFS. There was not an improvement in survival in this trial. So we need to wait and see what happens with this regimen based on the regulatory reviews. Another data set that was at the GU ASCO 25 symposium was the stopgap meta-analysis. This was a meta-analysis looking at individual patient data from various metastatic hormone-sensitive prostate cancer trials, including all the trials shown on this slide set. The bottom line take-home message from this meta-analysis is that there was a difference in the benefit based on the age group. Overall, there was a benefit. So essentially, the meta-analysis confirmed that the addition of a novel hormonal agent to ADT improves outcomes in patients with metastatic hormone-sensitive prostate cancer. But if you look at these subgroups and look at them by age, on the left-hand side, you see the abiraterone trials, the trials that added abiraterone to ADT. And the right-hand side, you see trials that added the amides like enzalutamide. And what you can see really is in the abiraterone group, in the elderly patient group that was 75 or older, there did not seem to be a benefit for adding abiraterone. So I think this gives us some food for thought. This is, again, a meta-analysis, not specifically a prospective trial looking at this elderly patient population. So I think that this suggests that we perhaps ought to be careful with this agent in the elderly patient age group 75 or older when you're trying to add abiraterone. I think that these data need further validation. I think that this is a careful discussion to be had with the patient based on this somewhat large meta-analysis that analyzed prospective trials. Now, I do want to highlight the ARANO trial. This was not a GUASCO 25, but I think this is an important data set which essentially showed that adding darolutamide to ADT in metastatic hormone-sensitive disease improves outcomes. So I think that this could be yet another novel hormonal agent that could be available right now. As you know, it is approved only in combination with docetaxel. So in this trial, it was darolutamide alone combined with ADT for metastatic hormone-sensitive disease. There was improvement in PFS, which appears similar to what we see with other agents in this setting. And we need to await regulatory reviews of these data, and hopefully darolutamide will also be available in this setting. There's a press release out there. This is not a presentation yet, which showed that or reported that capivasertib combined combination in hormone-sensitive prostate cancer combined with ADT and abiraterone led to an improvement in progression-free survival. And this is in patients who were PTEN deficient by IHC. So we need to wait and see what the data look like, and this is something to look out for in a future conference. So the take-home message, I think, is that the therapeutic landscape for advanced prostate cancer continues to evolve. We need to keep an eye on some of these data and consider the recent approval of lutetium PSMA for the first-line mCRPC setting, patients who are not exposed to docetaxel, as well as look out for regulatory reviews of the other data looking at combination of the radium-223 plus enzalutamide or the combination of ADT plus darolutamide in various settings of the disease. I'm going to switch to urothelial carcinoma. So urothelial carcinoma has also changed dramatically over the past few years. In the first-line setting, especially, as you can see, there has been the advent of enfortumab vedotin plus pembrolizumab, which remains the preferred standard in most patients that are either cisplatin eligible or cisplatin ineligible. I think GemCis-Nivo or Gem Platinum followed by avelumab. The Javelin paradigm continues to be a reasonable option in select patients who are not fit for EV pembrolizumab. Pembrolizumab monotherapy remains a reasonable option in patients who are neither cisplatin nor carboplatin eligible, so the least fit patients. Now, there are other salvage options, as we all know, with FGFR inhibition, erdafitinib. There's TDXD out there in HER2 IHC3 plus patients based on a pan-tumor tumor agnostic study. The EV302 trial is a landmark trial, so I thought I would highlight the update presented at the GU ASCO 2025 symposium. This is, of course, a trial that compared EV pembrolizumab versus platinum-based chemotherapy, gemcitabine platinum. So in the update, when you look at the overall progression-free survival, this approximately doubled from 6.3 months median to 12.5 months for EV pembrolizumab. Overall survival in the update was 33.8 months median versus 15.9 for chemotherapy. And again, hazard ratio is 0.51. Now, when you look at the subgroups based on cisplatin eligibility, in cisplatin eligible patients, you see the median survival is around 3 years, 36.7 months versus chemotherapy 18.7. In the cisplatin ineligible patients, you see the median survival is 25.6 months, closer to 2 years, versus approximately a year, 12.7 months for chemotherapy. So really, benefit was seen though, regardless of cisplatin eligibility when you look across both of these groups. Now, there's a duration of response update shown at the GU ASCO 25. So when you look at the duration of response, remember the response rate in this trial was approximately 68% for EV pembrolizumab. The median DOR is 23.3 months, so nearly 2 years for EV pembrolizumab, and 7 months for chemotherapy. When you look at the duration of complete response, again, a complete response rate was approximately 30% for EV pembrolizumab. So the median has not been reached for EV pembrolizumab. Around 75%, 74.3% are still in CR. Those who achieved CR, still in CR, 3/4 of them at 2 years. While with the Gem Platinum arm, 43.2% of CRs still in CR at 2 years. So really, I think these data further establish the strong role for EV pembrolizumab as the first-line therapy in most patients with advanced urothelial carcinoma. Next, moving on to the Niagara trial, which is also a practice-changing trial. This is a trial that looked at neoadjuvant gemcitabine cisplatin with or without perioperative durvalumab. So these patients in the experimental arm received durvalumab neoadjuvantly for 4 cycles, and then adjuvantly every 4 weeks for 8 cycles. And this, as you all know, is a positive trial with improvement in EFS, hazard ratio 0.68, OS hazard ratio 0.75. There was also a 10% improvement in pathologic complete response rate from around 27% for GemCis to around 37% for GemCis durvalumab. Now, the major update is the US FDA has approved this combination, as you all know, very recently, March 28th, very recently. So we have this as a novel regimen available for the neoadjuvant therapy of patients receiving gemcitabine cisplatin. In additional efficacy analysis of the GUSCO 25, the investigators reported outcomes based on whether the patient achieved a PAT-CR or not. The bottom line is whether the patients achieved PAT-CR or not, there was a benefit for the perioperative durvalumab arm. So from this analysis, we really cannot tell whether tease out the benefit from the adjuvant versus neoadjuvant component of durvalumab, but all we can say is there was a benefit regardless of PAT-CR for the combination of neoadjuvant and adjuvant durvalumab in the Niagara trial. The PAT-CR rate improved about 10%, like I said, by adding durvalumab. The toxicity profile is as expected with the addition of durvalumab with the immune adverse events. The key toxicity to note is that there was not a difference in patients that could undergo radical cystectomy. So really, it did not compromise the ability for the patients to undergo radical cystectomy. And the immune events are as expected with the addition of durvalumab. Immune adverse events in 21% of patients, but these were manageable. So Niagara remains a practice-changing trial based on this data and the update. The EFS and OS both improved. The OS improved with a hazard ratio of 0.75. PAT-CR improved, and the metastasis-free survival also improved actually in this trial. Moving on to the Checkmate 274 trial. This is the trial that looked at adjuvant nivolumab in high-risk muscle-invasive urothelial carcinoma. This, as we all know, is a positive trial. This has led to approval of nivolumab in the adjuvant setting of patients with high-risk muscle-invasive disease. So there was an update at the ASCO 25 symposium. So just to highlight the differential benefits here, outcomes here in the DFS in the all-comer group, as well as in patients that are PD-L1 high. So in the all-comer, everybody regardless of PD-L1, the median DFS improved from 8.5 months to 25.6 months, hazard ratio 0.63. And in the PD-L1 high group, defined as 1% or higher expression in the tumor cell, the median DFS improved from 8.4 months to 52.6 months, so exceeding 4 years median DFS in the PD-L1 high group. The hazard ratio in this group is 0.52. But as you can see, although the DFS hazard ratio appears more robust in the PD-L1 high group, there is a benefit in the intention to treat group also for DFS, which was the primary endpoint. And then when you look at overall survival, there are trends for improved survival for the adjuvant nivolumab arm. And this was, again, a secondary endpoint, but it's nice to see a strong trend for separation in the survival for adding nivolumab as adjuvant therapy. When you look at disease-free survival based on prior neoadjuvant chemotherapy or not, on initial analysis, it appeared that maybe neoadjuvant chemotherapy group benefited more. Now, what we see in the sub-analysis is both the groups benefit. That's the message. Patients with or without prior neoadjuvant chemotherapy benefited from adjuvant nivolumab. The hazard ratio is 0.58 in patients with prior neoadjuvant chemotherapy and 0.69 in patients without prior neoadjuvant chemotherapy. So although the hazard ratio is slightly less in in the group without prior neoadjuvant chemotherapy, both the groups appear to benefit. Again, these are unplanned, unpowered for sub-analyses. So really, with extended follow-up, adjuvant nivolumab continues to show a DFS benefit and also trends for overall survival benefit, regardless of neoadjuvant chemotherapy, and also regardless of PD-L1 status, high versus the intention to treat group. There's also data, as we all know, for subcutaneous nivolumab has been shown to be have similar PK effects and efficacy in RCC, and therefore there is an approval of subcutaneous nivolumab, and therefore you could use subcu nivolumab actually in this setting to provide an alternative that might be more convenient than IV nivolumab. So really, the take-home message is that EV pembrolizumab is a strong standard in the first-line therapy of advanced urothelial carcinoma. Uh, the addition of neoadjuvant durvalumab to neoadjuvant GemCis has provided a change in standard of care. And one of the problems that emerging is the impact of prior perioperative PD-1/L1 inhibition on the first-line therapy of advanced metastatic urothelial carcinoma needs further study. So what do we do with patients who receive GC durvalumab or adjuvant nivolumab when they progress? So that is a question that we need to study more, whether the reinstitution of immune checkpoint inhibition um, is a valid approach or not, needs further study. The advent of ctDNA continues to identify patients with MRD, and trials should be preferred to continue to make advances. Now, moving on quickly to RCC, the RCC therapy has changed also dramatically over the past 5 to 10 years. As we all know, various IO VEGF plus IO regimens, as well as an IO regimen, ipi-nivo, is available now for the first-line setting. And for subsequent therapies, we have various TKIs, including mTOR inhibition, mTOR plus TKI in the form of lenalidomide. And also now we have a HIF2 alpha inhibitor, belzutifan, approved in patients who are post-VEGF as well as IO exposure. Now, one of the things I want to highlight before we get into the GU ASCO updates is that ipi-nivolumab, of course, has level 1 data in intermediate and poorest disease from the checkmate trial. But now with further follow-up, ipi-nivo has looked more and more impressive, even in the favorable risk group, which that trial did enroll. And there is now separation of the survival curve in favor of ipi-nivo compared to sunitinib. Now, again, the trial was not powered for that. Therefore, the level of evidence for this remains like a category 2, but it is now one of the regimens that considered reasonable in patients with even favorable risk disease. Now, there was an update in the Checkmate 9ER trial. This is the cabo-nivo versus sunitinib first-line clear cell RCC trial. So in the update at GU ASCO 25, there was a continued benefit of PFS seen with separation of the PFS curves for a very long time, beyond 5 years. The median PFS 16.4 months versus sunitinib 8.3 months. And the overall survival also prolonged from approximately 3 years for sunitinib, 35.5 months, to approximately 4 years for cabo-nivo, 46.5 months. There was an improvement in the response rate. So again, validates what we've seen before, approximately 56% response rate for cabo-nivo. And also the median duration of response for cabo-nivo is close to 2 years, 22 months. The median DOR for sunitinib was 15.2 months. And really, when you look at across the patients that were untreated, you see a benefit across favorable as well as intermediate and poor risk groups for PFS. When you look at it by disease metastatic site groups, you see a benefit across all of the sites of metastases, but perhaps a little more robust hazard ratio for PFS in the bone metastasis group, which we have suspected for a long time. But regardless, there was a benefit regardless of metastatic site, lung, bone, or liver. So really long-term efficacy benefit for cabo-nivo was shown again in this update at the GU ASCO Symposium. The next trial I wanted to highlight is not actually practice changing, but it is a trial that shows us some of the future directions in which drug development is going. This is the Keymaker U03 trial. This is a combination of pembrolizumab with various targeted therapies for advanced clear cell RCC progressing after prior PD-1/L1 inhibition therapy. So really we'll focus on, this is a randomized phase 2 trial, not phase 3. And I just want to focus on these 3 arms here, which is basically the pembro, belzutifan, len belzutifan, or len pembro. And really the bottom line, just to cut to the chase, is that the combination of len belzutifan looked promising in this 3-arm cohort study, which was reported so far. 46.9% response rate for len belzutifan after prior PD-1/L1 inhibition. The median DOR also quite impressive at 22.1 months. When you look at the PFS, median PFS, about 1 year, 12.5 months for len belzutifan, looking more impressive than len pembro or belzutifan pembro. This is again in the post PD-1 L1 inhibitor setting. So really the combination of len belzutifan looked impressive in this salvage post PD-1 L1 inhibitor setting trial. And really what's going on now is the ongoing phase 3 trial, LightSpark 011, which is actually comparing len belzutifan versus cabozantinib as salvage therapy after prior immune checkpoint inhibitor inhibition-based therapy. So we need to wait for the data from that to validate some of this exciting data we're seeing for combination VEGF inhibition plus HIF2 alpha inhibition. Now, there's a molecule called KIM1 that has received a lot of attention recently as a marker for MRD, minimal residual disease in clear cell RCC. So this is a study here where the investigators looked at KIM1 as a prognostic and predictive biomarker in patients with advanced RCC receiving either ipi/nivo or sunitinib. This is the phase 3 trial that led to the approval of ipi/nivo. So the background data is that there's recent data from last year which showed that KIM1 might be a marker for benefit from adjuvant atezolizumab. So again, in the adjuvant atezo phase 3 trial, which was a negative trial, the investigators showed that the post-op KIM1 high group appeared to benefit while the KIM1 low group did not. And also the on-treatment increase or decrease in KIM1 was associated with outcomes. And KIM1, again, this was a blood proteomic marker. Just to be clear, this has also been looked at in tumor tissue, but in this case, in all of these studies I'm showing you here, this is the blood-based proteomic KIM1 that was studied. So in this Checkmate 214 trial, ipi/nivo versus sunitinib, the investigators looked at KIM1. So the bottom line is higher baseline KIM1 was associated with worse outcomes. This is regardless of treatment, worse outcomes. What was also interesting is that the decrease in KIM1 at 3 weeks after treatment started was strongly associated with subsequent outcomes in the ipi/nivo arm, but not the sunitinib arm. So somehow dynamic changes in the ipi/nivo arm were prognostic for better outcomes, while in the sunitinib arm they were not, suggesting perhaps that a change in the immune checkpoint inhibitor setting may be mechanistically provide or be associated with favorable outcomes when KIM1 decreases. So really, these data need further validation. KIM1 data set for supporting KIM1 as a marker for MRD in the setting of immune checkpoint inhibition continues to accumulate. So we need to wait for further data, perhaps prospective validation, to hopefully be able to use it someday in the clinic to make clinical decisions. So really, at this time, the treatment of RCC remains what it has been. No practice changing data at this point from GU ASCO, but we need to wait for further data from the ongoing phase 3 trials evaluating HIF2 alpha inhibition. Next, I wanted to show one trial that is beyond the big 3 GU cancers. This is penile cancer, which gets very little attention. As we all know, in the penile cancer setting, cisplatin-based chemotherapy is favored. TIP or cisplatin 5, if you frequently been used in the first-line setting of advanced penile cancer. It's a very unmet need setting. The median survival with this regimen is under 1 year, so very resistant with lots of de novo resistance in this cancer. So this phase 2 trial combines cisplatin-based chemotherapy, either TIP or cisplatin 5FU, with cemiplimab, a PD-1 inhibitor. The regimen was 4 cycles of cisplatin-based chemo combined with cemiplimab, and then cemiplimab could continue up to a total of 2 years. As you can see, objective response rate was 51.7%, so somewhat impressive, because with cisplatin-based chemo, you tend to get around a 30% response rate, again, comparing across different studies. So this is an impressive response rate. Also an impressive median survival, 15.5 months, crossing the 1 year boundary, which we've still not crossed with a first-line metastatic disease regimen, and a median PFS of 6.2 months. And some of the responders had durable responses. So really the EPIC-8 trial provides, I think, preliminary evidence for efficacy and activity of cisplatin-based chemotherapy combined with PD-1 inhibition therapy with cemiplimab, and further data and further validation would be welcome in the future. But I think this is a welcome advance in this disease, and hopefully we will be able to get this into the clinic someday. Thank you.